We are very, very excited, as always, to have you here. I'm seeing many faces for the second or third time, so welcome back. And very happy to have you support us once again and be part of the 38th Annual Legislative Conference. As you know, we work diligently at the Congressional Black Caucus Foundation, along with the Health Brain Trust, both to identify and to address important health issues that affect the African American community. We had some interesting internal conversations at the foundation when we thought about which issue to address in particular this year. And something came to mind that was actually very personal, and allow me to share a very, very quick story with you. I think it was about 6 or 7 years ago or so. I got a call from my mom. Both of my parents live in New York. And she shared with me that she had bumped into my dad coming home from work one day. She actually had stopped to pick up some dry cleaning. And my dad had decided not to drive into the train station as he always did, and he had taken the bus. So they happened to have bumped into each other about 3 avenues or 6 city blocks away from where we live in New York. As they were walking, and my mom actually had a bunch of dry cleaning that she had picked up, she suddenly realized that my dad was not keeping up with her. And she turned around, and he was quite a bit of a ways behind her. She asked him if he was okay, and he said he felt draggy, but he was trying really hard to keep up with her. Long and short of it is, the next time she turned around, he was literally almost half a city block away behind her. And that's when she realized something was not right. She told him that he should go to the doctors as soon as possible. He went the next day to the emergency room after contacting his primary care physician. They admitted him right then and there and performed triple bypass on him the next morning. That triple bypass saved my dad's life. Doctor literally told him that he was 2 steps away from having a massive heart attack and that he probably would not have survived. Well, I'd always heard about heart disease. I studied it at school. It never got more personal than that for me. And when I thought about it and knew that September was also a very important month around cardiovascular disease, I said, you know what, this is going to be the topic. So I'm very happy that you are all here so we can hear about how important it is to deal with this problem. As you all know, it affects not just African American men and women, but all people. It's the #1 killer. And there are a lot of excellent efforts that are happening out there to try to deal with it, to raise the alert, and to really get people to make some real important changes. So we actually have not 1 but 2 great speakers this year, so we're really, really excited about that. Please go ahead and continue to eat. We are starting a little bit earlier because Dr. ALC Scott, who is the president and CEO of the Congressional Black Caucus Foundation, and Congresswoman Donna Christensen, who is also the chair of besides being the only African-American woman physician in Congress, is also the chair of the Health Brain Trust of the Congressional Black Caucus. Both need to leave a little bit early, but as always, are firmly here to support us during this event. So right now, I'll introduce to you Dr. ALC Scott.
Thank you, Dr. Innocent. Good afternoon, everybody. It is so good to have you back with us. Many of you I recognize your faces. This is the 3rd year of this luncheon. I remember the first year we had this luncheon, and when we started talking about we wanted to do a luncheon around health issues during the Future Focus series, and immediately Ernest McGuigan and Pepsi stepped to the table and said we would like to be a sponsor of this, and they have been with us every year since, and so we appreciate having them here as our sponsor. You know, every year we try to take a critical issue in the African American community and highlight it. Last year we highlighted mental health, and this year we're highlighting healthy heart. Because there are so many health issues that are so near and dear to so many of us. You know, we started talking, Marjorie made it very personal earlier, and we talked to everybody in here. Many people will have personal stories about conditions. It may not be heart, it may be diabetes, it may be hypertension, but all of us have stories in our family of health problems. And so therefore, the Congressional Black Caucus Foundation has chosen to place a big emphasis on health. This is one of our 3 major focus areas. The other 2 are education and economic development. And we have been doing a lot of our work through our Black Health Empowerment Program, but we also have been working with Congresswoman Christensen around health disparities, because not only does she chair the Health Brain Trust for the Congressional Black Caucus, she also chairs the Health Committee of the Congressional Black Caucus Foundation. So she has helped us to really get focused. She's also helped us to get the resources we need in order to look at policy issues as well as look at personal responsibility. Because, we can sit around and we can talk about what the government has done to keep us from having good health, but we also recognize that there are some things we need to do ourselves. So what we would like to see is not either or. It is a marriage of the 2, some personal responsibility, but also not letting the government off the hook for what they're doing to harm the health of so many people in this country. So I am so happy to be here, and as Marjorie mentioned that, this is the first day of our conference, and if you saw my schedule, you'd see that there is no way I could make it to all of the events that I have on my schedule. But I want to thank Dr. Yancy for taking time out of your busy schedule and joining us today. I hate that I'm going to miss your remarks, but I'm sure I'll hear about it from my staff and from people who are attending here today. So I'm going to have to run, but at this time, what I would like to do is introduce Congresswoman Christensen. I don't have to introduce her to you because she's a part of this community. And you all know her very well for all the work she has done. And she's a very valuable member of the Foundation Board, of the Congressional Black Caucus, of the Congress of the United States, of the Virgin Islands. We just love her. Congresswoman Christensen.
Thank you, ALC, for that short but really packed with all kinds of nice things introduction. And good afternoon, everyone. And welcome. It's a pleasure to see you here and to be here with you as you address a very important issue, heart disease, the leading cause of death in our country, but with a devastating impact on the African American community. I'm pleased to bring greetings from the Health Brain Trust of the Congressional Black Caucus, as well as from our other minority caucuses. Together we call ourselves a Tri-Caucus. That's the Hispanic and Asian Pacific Island Caucus. And before I begin, I want to also thank and acknowledge Drs. ALC Scott and Marjorie Innocent of the Foundation for their leadership and for the outstanding work that they're doing in bringing expertise and insights into so many of the challenges that we face as an African American community. I also want to thank our sponsor. We've been very fortunate that PepsiCo has supported so many of our efforts to raise awareness around key minority health issues, and today's partnership is no different, so we thank you. I also want to acknowledge our keynote speaker, Dr. Clyde Yancy of the American Heart Association. We thank you for bringing your expertise to this critically important issue and sharing that expertise with our guests here today. As a physician who practiced for more than 2 decades before coming to Congress, I had the opportunity to see firsthand the devastating impact that heart disease has on the African Americans who are afflicted with this condition, on their families, and even on their communities. And while I know that Dr. Yancy will address the disproportionate and detrimental impact that heart disease has on African Americans, there's several sad ironies and key drivers of the disease that I just want to highlight in my brief remarks. First, while heart disease also affects men, far too many women, including African American women, who are disproportionately more at risk for heart disease than their white counterparts, falsely assume that heart disease is a man's disease. However, I'm sure, as Dr. Yancy will confirm, this assumption could not be further from the truth. In fact, heart disease is the #1 killer of women in this country, claiming the life of 1 in 4 women every year. And the other sad irony of heart disease is that, like so many of the other diseases, it's one with noted racial and ethnic health disparities. And I'm not going to go into the statistics, but I do want to stress that these disparities have several causes. Elsie mentioned lifestyle-related causes such as overweight, obesity, smoking, and inactivity. But in our work, both at the foundation and in the Health Brain Trust, we choose to focus on others, such as the known racial and ethnic differences in the quality of cardiac care. Our own Julia Carson, who died in this Congress, having been a poster woman for what too often happens when black women present with the complaint of chest pain. It's treated lightly. She was told she had indigestion. And so we suffer greatly from that kind of discrimination, and we can't ignore the role that uninsurance or underinsurance also plays. These latter are the issues that we have kept and will continue to keep at the forefront of our discussions and efforts to achieve health disparity elimination. And we have a bill that gets at this. It's H.R. 3014, the Health Equity and Accountability Act of 2007. We are very clear at the Congressional Black Caucus that it's our responsibility as your representatives to change the system in which the lack of access to equal quality health care makes it almost of no consequence if a person of color changes their lifestyle, because it's a system in which you will still be more likely to die prematurely from preventable causes because of the discrimination in the system. So not only does our bill aim to address some of the causes of disparities in heart disease, but it also aims to wipe out the foundation upon which all health disparities, racial and ethnic, gender and rural, exist. And it does so by tackling the social determinants of health that detrimentally affect African Americans, other racial and ethnic minorities, and rural populations. Because in addition to addressing the disparities in the system of care, we know from mountains of research that exist that the disparities we see today in heart disease, as well as in nearly every other chronic and acute condition with noted health disparities, that they're also the result of many dynamics that exist outside of the healthcare system. Where you live, both in terms of geography and the physical structures in your neighborhood, what you eat, your educational attainment, your socioeconomic status, your race and ethnicity, and your gender and language are all social determinants that have a direct and indirect impact on your health and health care. Many more know now from the series Unnatural Causes, which recently aired on PBS and which we showcased in our Spring Brain Trust, and from great studies that have come out of the Joint Center, the Opportunity Agenda, and the Praxis Project, that the health of African Americans and other racial and ethnic minorities is disproportionately more likely to be detrimentally affected by social determinants, by the social determinants of health. For example, African Americans and other racial and ethnic minorities are disproportionately more likely than whites to live in poverty, a social determinant of health. In fact, more than half of non-elderly African Americans, Hispanics, and Native Americans, compared to less than 1/4 of all whites, more than half of them, compared to less than 1/4 of whites, are considered to be poor or near poor. When we look at the percentage of elderly Americans who are poor or near poor, more than half of all elderly Americans of color, compared to 38 of white elderly Americans, fall into one of those categories. Studies also show that overall racial and ethnic minorities have lower level of educational attainment than whites and thus tend to earn less money and work in jobs that are prone to injuries. Reports also confirm that there's a strong and direct correlation between income and health status and life expectancy. We also know that racial and ethnic minorities are more likely to live in neighborhoods that have terrible housing conditions, as well as higher levels of garbage and uncollected waste and other pollutants that studies confirm also contribute to poorer health and lower life expectancy. Racial and ethnic minorities, particularly those in low-income urban areas, are disproportionately more likely than whites to live in neighborhoods with numerous fast food options, but few available, affordable, healthy food options, and a plethora of liquor stores and cigarette advertisements. And we can look right here in Washington, D.C. to see the impact of that. Additionally, African Americans and other racial and ethnic minorities are more likely to live in neighborhoods with higher crime rates and fewer safe exercise options. When you consider these factors together, it's very easy to see how and why social determinants of health increase the risks for heart disease in African Americans. For example, we know that overweight and obesity, inactivity and smoking are among the 3 leading risk factors for heart disease. Well, if you live in a neighborhood where you could not walk or run outside, where you could purchase 5 jumbo hot dogs and 5 bags of potato chips for less money than it costs to purchase a healthier food option of a smaller quantity, and if you live in a situation and in a neighborhood where, due to the daily stress you are confronted with, that constant bombardment of easy access to cheap alcohol and cigarettes that was sold at highly discounted prices were so tempting they couldn't be ignored. Well, if that's the reality, how healthy can most of us be? And how difficult is it for many of us to make healthier decisions? So it's tough, and the social determinants of health that have a noted and often deleterious impact on minority health too often, and in far too many of our neighborhoods, do not make healthy choices available to us as they should be. And of course, there's also an increasing body of knowledge that indicates how stress may not only cause heart disease and other chronic diseases, either directly or indirectly, but we know that it can exacerbate existing diseases and reduce the likelihood that one will adhere to prescribed treatment regimens. I don't have to detail here for any of you that African Americans at every economic level suffer from some degree of chronic stress. Addressing all of these factors, therefore, must be an integral part of our efforts, all of our efforts, not only to reverse the tide of heart disease in our community and to reverse the tide of every disease and condition that has a negative impact on our health care, wellness, and thus life opportunities. My colleagues and I in the Caucus, as often as possible, have done that together. We have championed health legislation over the last 3 Congresses, such as H.R. 3014, which works not only to reduce health disparities in a public health sense across chronic and acute conditions and issues of health quality and access, but also addresses the social determinants of health that we know are at the root causes of these disparities. But we can't do it alone. And so we invite you, all of you, to stand with us on common ground with a unified voice as we call for health equity. The time to make diseases like heart disease, the subject of our discussion today, as well as HIV, AIDS, diabetes, and healthcare issues like uninsurance and disparate quality, we need to make them topics of the past. And as we move forward to a new political day of change and hope, we look forward to continue this work in the Democratic Congress with a larger majority and with the Democratic President Barack Obama, both of which we are depending both of which we're depending on you to help deliver, to work to ensure that no other black woman has to go through what Julia Carson had to, or black person, man or woman, has to go through what Julia Carson had to go through to get the care that she needed and got too late for her heart disease. To eliminate health disparities and address the social determinants of health that rob too many of our community's brightest and most gifted from achieving their full life potential. So thank you, and again, welcome.
Now, please welcome Ernest McFadden from PepsiCo.
Good afternoon. Wow, what a wonderful day, and sitting down in my seat, I feel a little bit out of place because I'm coming after all these doctors. And I am Ernest McFadden, manager of global citizenship for PepsiCo, and I'm not a doctor, but you have a dynamic speaker and a doctor coming to you after lunch. So on behalf of PepsiCo and our some 164,000 associates around the world, it is just a delight to continue to partner with the Congressional Black Caucus Foundation on such important issues that impact our community. I do want to acknowledge one of my colleagues that's here, and I'm expecting a few more, Omar Vargas from our Government Affairs Office. Thanks for coming and joining us today. PepsiCo has had a long-standing relationship with the Congressional Black Caucus Foundation and these vital programs. This is a complex issue. Make no mistake about it. As Dr. Innocent described in her remarks, the tragedy that potentially could have took place in her family, each one of us can probably look back our family tree and say, well, that was my uncle, that was my cousin, that was my mother. So it's an issue that we take very seriously, and PepsiCo has been in the forefront of a number of initiatives. We have partnered with the Clinton Foundation and the American Heart Association around the issue around obesity and removing higher calorie, higher sugar product out of the schools. We did that voluntarily. We also pushed by the year 2010 that over 50% of our product would be what we call good for you, better for you. Essentially means that it has lower calories, lower sugar, single serve packaging available to our consumers. But make no mistake about it, we are a company, we do have shareholders that we need to respond to. And I think part of the issue, we can't lose sight of the fact that there is a personal responsibility as well. As Congresswoman Christensen described in terms of in our community and communities in general, if we look internally and say, hey, what is it that I can do more? I mean, I know I can get my butt out of bed and run a little bit more in the morning. So I think it's those simple things that we need to do in terms of take personal responsibility. But again, this is a very serious issue. PepsiCo and its family take it very seriously. And we believe that it's a complex problem. No one industry, no one person can solve it. It has to be a collective work. We feel that we're doing our part by making sure that either product, programs that we support respond to America's cry. Obesity, again, is a complex issue, and certainly those are contributing factors to heart disease that our country finds ourselves in. I read something in a magazine that some 80%, and if I'm wrong, certainly the doctor will correct me, some 80% of heart disease that's out there, some of it is preventable simply by choices that we make as we go through our daily lives. So I'm in the position of coming to you as you're eating, and I want to be certainly respectful and mindful of your time that you've taken to come here to hear from an industry expert, to hear from Dr. Yancy, who's going to share with you some issues, some things that hopefully we can take from this conference and go back and apply it in our own lives. And I'm a firm believer in I am my brother's keeper or my sister's keeper, that we all can go back and say, hey, Uncle Charlie, get off the chair. Let's walk around the block today. Let's do this. So the challenges that I would leave for us today is hearing the message from Dr. Yancy. When we leave here, let's commit. Let's go back and find someone in our own family that we can take and allow them to start taking some personal responsibility as well. So, again, on behalf of PepsiCo and our some 168,000 associates, welcome to the Health Forum. Welcome to the Congressional Black Caucus 30th Annual Legislative Conference. And please, leave here with a purpose. Leave here with something that you're going to take back and apply within your own personal life or in your community. Thank you.
Thank you so much, Ernest. As he mentioned, the Congressional Black Caucus Foundation and PepsiCo have a very strong and long-standing relationship in developing programs that address health issues in our community. This luncheon, of course, is one of them. PepsiCo is also the sponsor of our health policy, our Louis Stokes Health Policy Fellowship Program. And our two incoming health policy fellows are actually here, and just wanted to introduce them. Camille Seeley and Julia Elam. We're looking forward to working with them this year. Very, very proud of them. Now, ladies and gentlemen, please allow me to introduce to you the current medical director at Baylor Heart and Vascular Institute and chief of cardiothoracic transplantation at Baylor University Medical Center, and the incoming president of the American Heart Association, Dr. Clyde Yancy.
Level check, test 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Level check, test 1, 2. You good?
Good afternoon. How are you? It is a pleasure to be here, and I'd like to acknowledge, first of all, Dr. Scott, the president of the Congressional Black Caucus Foundation. I'd like to acknowledge Congressman Christensen, and I appreciate your efforts on Capitol Hill to blend medicine and politics. It can't be easy, so I appreciate what you're doing. And I'd especially like to extend a debt of gratitude towards Dr. Innocent for her very kind invitation and for giving me the opportunity to humbly bring a message before you that I hope you will embrace and to align that message with the efforts of the American Heart Association. Let me impose a little request on you before we get started. For the next 30 seconds, I want you to stop eating and just be very quiet, and I'll time it. So starting now, everyone just stop moving and just give us 30 seconds. In the time that you've been quiet, somebody just died from heart disease. If we did this exercise for another 15 seconds, someone will have just had a stroke, and they would have had a 50% chance of dying, 60% chance if they were African American. That is the burden of heart disease. The tables to my left, everyone at these tables, raise your hand, starting from the table here to the left. If I were speaking to a general lay audience, I would say 40% of the people in this room, which that approximately represents, will die from heart disease and stroke. Keep your hands up. Now, everyone in this table, these three tables, raise your hand. When I'm speaking to an African American community, it's now 60%. So this is the percent of people in this room that are likely to die from heart disease and stroke. And so this is a very real issue. Can you still hear me? Right. So I recognize that an organization that is aligned with a political objective has lots of issues on its plate. But I want to make a plea to you right now and indicate that nothing, and I truly mean this, nothing can be more important to the future of our country and to the future of the constituency you represent than to understand the burden of heart disease and stroke and to do something proactive to address that burden. This is who I am, and Dr. Innocent has told you that, and I show you this slide that's titled Disclosures just to convince you that I don't represent anyone else other than the American Heart Association and a cause to reduce heart disease and stroke. I have no industry affiliations. I work with the FDA, the NIH, and the American Heart Association. So let's start with something that's very important. This country is changing. This country is no longer a majority white country. Within the next 2 decades, there will not be a majority. There will be a number of pluralities. Even though right now you can see that whites represent 60 to 70%, the most recent census figures indicate that by 2030, 2040 at the latest, that number will be less than 50%, and the proportion of Asians, those of Hispanic descent, and those of African descent will constitute the bulk of the remainder of the population. So it is appropriate public health policy, not special health policy, to be focused on the health affairs of all citizens, especially those that happen to be minorities. Now let's take some graphics here that really make the case. Every woman in this room is sensitive to your risk of breast cancer. You should be, because African American women get breast cancer at a later stage when it's developed and have a higher risk of death due to breast cancer, which is exactly how I lost my wife. So I know it's a real disease and it affects African American women. But if you look at the penetration of breast cancer as an illness that affects African American women, that's at 34, and this is the number of deaths per 100,000 in the population, 34. Now look at the risk of coronary heart disease and stroke for black women in the white bar, 170 per 100,000, or 4 times higher. And if you put stroke and coronary heart disease together, that ends up being 250, almost tenfold higher than the risk of breast cancer. And as sensitive as African American women should be to the risk of breast cancer, the risk of heart disease and stroke is nearly 10 times higher. This is why I personally have such conviction here, because this is what's likely to take us out. Even though lung cancer is a real disease and a real concern, again, 10 times more likely to have heart attack or stroke if you're an African American woman. What about the risk of death? So you have a stroke. Who is likely to die when a stroke occurs? And it's a very disturbing graphic, because irregardless of the age groups, and the age groups are outlined here, if you look at non-Hispanic blacks, we lead the way. When we have a stroke, our risk of death is dramatically higher. Why? Because the kind of stroke we have is much more compelling. Typically, the kind of stroke we have is what we in medicine call a hemorrhagic stroke. So let's do a little bit of a vocabulary test. What is a stroke? Now, I don't expect you to answer because that would be putting you on the spot. But a stroke is the death of brain cells. And it's the death of brain cells because either you don't get blood supply to the brain or a blood vessel bursts in the brain. Now, for African Americans, the kind of stroke that's likely to occur is where the blood vessel bursts. Why? Because we have such beat-the-band high blood pressure. The kind of stroke that others get is a stroke where there's a clot that goes to a blood vessel in the brain because of hardening of the arteries or atherosclerosis, the consequences of which are easier to treat and the outcomes are better. But when a vessel bursts, that's almost instantaneous death. And that's the kind of risk we have. If we take this further and we look at what I just shared with you, this burden of hypertension, nothing could be more compelling. This is the percent of the population. Now, what I want you to do is look very carefully at non-Hispanic black or African American men, non-Hispanic black or African American women. Far and away, we lead the list. Now, if you really put this in context, what this is telling us is that at least 1 in 2 African Americans of any age, already have high blood pressure. If you take young African American women up to the age of 35, by the age of 35, African American women have a 1 in 3 chance of already being hypertensive by the age of 35. And I can guarantee you that 1/3 of African women under the age of 35 are not being treated for their high blood pressure, yet they already have the burden of a risk factor that is likely to cause serious problems. What about diabetes? We at least have some company here because Hispanics have nearly as high or higher rates of diabetes as we do. But nevertheless, when you compare the percent of the population with diabetes for non-Hispanic whites versus non-Hispanic blacks versus Mexican Americans, you see the story. You do the same thing for women, it's even more compelling. So let me start off by saying that everything is not bad. There is some good news here. We in the American Heart Association adopted a goal in the year 2000 of reducing death and disability due to heart disease and stroke by 25% at the year 2010, and we've reached that goal, and so we're happy about that. And it turns out that for African Americans, we have seen some decrements. So we have been a part of that change, but not at the same rate of change. Deaths for coronary heart disease, which is what a layperson would call a heart attack. By the way, how many of you are eating the sauce on that chicken today? How many put the dressing on their salad today? How many took that little pat of butter and put that on your bread today? I don't need to finish that thought, do I? All right. So age-adjusted death rates for heart attack down 24%, stroke down 20%, which is good. But there's a but here that is very important. And some of the things I'm going to share with you are very sobering. For African Americans in the population, the risk of death due to heart disease and stroke, 22% higher. That's why I said these tables needed to raise their hand, because that's the extra burden that being black carries with regards to your risk of heart disease and stroke. Twice as likely to have a stroke to begin with, and much more likely to die from a stroke. High blood pressure affects blacks more than any other group in the world. Not in this country, in the world. Women that happen to be African American not only have a high burden of diabetes, but here's the part where we have to be very careful. But unfortunately, African American women have the highest rate of obesity. Now, let me give you a perspective on this, and I'm not making eye contact with anyone because I know I'll never make it back to Texas. But let's just presume that somewhere in space there is an African American woman that weighs 200 pounds. I'm not looking at anybody. All right? If you weigh 200 pounds, or you know someone who weighs 200 pounds, the height that that woman would have to be for 200 pounds to be a healthy weight is 6 foot 5 inches tall. There's nobody in this room that's 6'5". So anyone that's at the 200-pound threshold, there's something that needs to be done, because it's a huge burden, and I mean to use the word huge, because it predisposes to diabetes, it predisposes to hardening of the arteries, it predisposes to premature death. 45% of all black women, nearly half of the women in this room, have some form of cardiovascular disease right now. If I brought the same number of women that were not black in this room, it'd be only 20%. It's an unacceptably high burden, unacceptably high. There is a gap in life expectancy. I'm not expected to live as long as my white peers. At least a third of that gap, and at this age, I'm 50, more than half of that gap is due to heart disease and stroke. At younger ages, a lot of that's due to trauma and homicide, etc. But at least a third is due to heart disease and stroke. What else can I tell you? This is further compounded because as a population, fewer African Americans are insured. Access to health insurance is also related to having better outcomes. There is a phenomenon that is developing in the parlance of CMS, and I'm sure that Congressman Christensen knows about this, but it's the designation of a medical home. A medical home is not a soft, touchy-feely phrase. It's a very important concept. It means that you have someplace to go to. You have someone to call. There is someone that knows about you, so that when you say you have a problem, somebody responds to your problem, and you don't show up at a generic emergency room and wait in line for somebody that's been up all night to tell you that there's nothing wrong and send you home and tell you your chest pain is GI upset and you're dead the next day. That's why you want a medical home. When you have a medical home, you do better. You need insurance. If you don't have insurance, you don't have a medical home. It's very straightforward. When you show up, because we show up so ill, a much higher likelihood of being admitted to the hospital. We use emergency rooms as our primary care facility. If we get an operation, we tend to do least well because we go into the operating room least healthy. And here's the part that is most sobering. Heart disease rates for the poorest Americans, and we know who they are, at least 50% higher than for the most affluent Americans. And it's all related to access. This is putting the mirror on me now because it looks at who's in the workforce taking care of those with heart disease. Unfortunately, it's not us. Even though we represent 12% of the population, I represent one of only about 600 African American cardiologists in this country. That is abysmal when you consider the burden of heart disease that we bear. If you look at medical schools, just 4 years ago, less than 10%, even down to 5%, were graduating African Americans from medical school. And when they graduate from medical school, because they graduate with a high debt, they immediately start working. So they go into primary care practices. They don't go for subspecialization. So the kind of focus we need, especially at the research level, isn't there. And that is something that needs to be addressed. Now, on your tables, you have a brochure inviting you to attend a conference in December that is addressing healthcare disparities. So here's vocabulary lesson 2. What's a disparity? Again, I don't expect anyone to speak up. But what I'm going to share with you is an important statement that helps you contrast a healthcare difference from a healthcare disparity, and you'll understand what I'm getting at. In 2000 to 2001, the Institute of Medicine commissioned a group of individuals to review the quality of healthcare in this country. And part of their report was to address the fact that we have a major issue with differences in outcomes. So let me walk you through this. On this horizontal plane, this is populations with equal access to health care. So we've taken the access part out of the equation. And on the vertical plane, we've put the quality of health care. As a matter of statement, non-minority versus minority, there is higher quality in non-minorities. That represents a difference. But what's important is to look at what the difference represents. Sometimes outcomes are different because we as humans are different. We have different diseases, we present at different stages, we want or don't want to have different things done. That falls into the top box, your preference. You have a right to choose, particularly in this country. But it's in these two boxes that we all have great concern. Because what a disparate circumstance is when your health care is modified because of a language barrier, a cultural barrier, a financial barrier, or worse, bias, or stereotyping, or frank racism. That's a disparity. Just because there's a difference between two groups of people doesn't necessarily mean there's a disparity. The strict definition of a disparity is due to these clearly arbitrary non-medical circumstances. So, for example, if you look at the treatment for a heart attack, those that come in with a heart attack that happen to be minority don't get the state-of-the-art treatment nearly as often. That's what the second bullet is that has to do with the particular agent given to treat heart attacks. The next point, even when it's identified that you have blocked blood vessel disease around your heart and the right strategy is bypass surgery, as Dr. Innocent described, African Americans and other minorities are less likely to have that surgery done despite having the same disease. If you're trying to put this into a context, you have to wrestle with the most disturbing part of this, which has to do with bias, stereotyping, and prejudice. This is the publication I referred to. It's called Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. So if you talk to ordinary citizens and you want to find out what do you think the healthcare status is, if you talk to whites and ask them about the health care of African Americans, this yellow box here, which is about the same, is the majority opinion. So if you say, what do you think the health care of an African American is? About the same, worse than, or better than? 50% of whites say it's about the same. You talk to African Americans and the truth comes out. 65% say it's clearly worse than. But this is the part that's most sobering. Let's use the breast cancer situation. Let's just talk about mammograms. Nobody should refuse a mammogram. There's no reason not to have one. So we can throw that part of the equation out. So does it actually happen? No. Because even though everyone should have screening at the same rate, African American women, again, 10 to 20% less likely to have the mammogram done, and the physician prompts that. And so someone is making a cognitive decision that you aren't at risk. And in fact, you are at the same risk, if not higher. So why does this occur? I mean, do we just have mean people in the healthcare system that just don't care? I would like to think that's not the case. But let me walk you through a dynamic that does happen in medicine. And so if you look at this interface, this is the critical interface of a provider and a patient. There's an interview, there's an examination done, and data points are obtained. You have your physical examination, you have your lab test done. And then the data have to be interpreted. And this is where it changes, because they're interpreted within the context of certain social and economic influences. They are interpreted within the context of stereotyping. They're interpreted within the context of cultural awareness or cultural insensitivity. Here is the deal. After you interpret all of this information, there is an intervention. It's what we as doctors do. The blue stars show the very best decision making. The black stars show the very poorest decision making. The same data points can come in on any given patient. But if the provider follows this path of cultural insensitivity, stereotyping, or prejudice, you make poor decisions. If, on the other hand, the interpretation reflects the sensitivity to who the patient is and a desire to help, and the financial issues are appropriate, then you get the blue stars. It's a very straightforward issue, but that's what this is all about. So I'd like to kind of share something with you that is a little bit disquieting, but I think it gets to the point. So the focus here is in part on bias, but let's just pick stereotyping for the sake of time. Stereotyping means evidence suggests that physicians would use cognitive shortcuts. That is, you would see someone and presume that the someone you see is more or less likely to have a problem. So if we talk about this, it means that people use social categories in acquiring, processing, and recalling information about others. And so what do you think are the prevailing stereotypes when providers think about African Americans? Well, let me show you what is in Wikipedia if you search today. This is not a search in 1950. This is a search today, in 2007, 2008. There is a link, and you can do this on your own if you'd like. But this is the current stereotype. Animalistic brutes, physically oriented, hedonistic, criminal-minded, violent, unrestrained, hot-tempered, and profane. If you separate out women, grossly overweight, poorly made up, gaudy attire, genial, spiritual to the point of delusion. If you take African American men, intellectually, economically, and culturally inadequate. I didn't date this 1950. This is a recent search. These are the prevailing stereotypes, and this is the subconscious current that is influencing decision-making and the distribution of healthcare, and that's a problem. So let me move forward and share with you an experience that I've had in my research career, because my area of interest, I don't like to use the word expertise because I'm not sure what an expert is, but my area of interest is in a disease called heart failure. African Americans are much more likely to have heart failure than others. We became aware, we being a group of investigators, that the outcomes for African Americans on standard therapy were not as good. And there was an inkling from early research that there may have been a unique therapy that might have been beneficial. Some of you have heard of the drug I'm getting up to. It's called Bidil, B-I-D-I-L. So we did the definitive study, African American heart failure trial. I was one of the 6 or 7 people in charge of this. And we demonstrated that not only was the drug effective, it was incredibly effective to the point that we had to stop the study early because it wasn't ethical to continue. We had to stop the study early and make it available to others. And this was a difference we saw. This is with the experimental therapy. This is with a dummy tablet on the background of otherwise appropriate therapy. Everybody lauded this as out of the park, home run, blockbuster, amazing research. It was published in the New England Journal of Medicine. It was an extraordinary run. Did it make a difference? Well, even those of us in the medical establishment that direct physicians on how they should care for patients said, yes, it does. And we gave it a very high degree of certainty as being beneficial. These are called guidelines, and physicians are expected to follow those. But this is what I'm getting at. These are recent data. I just published these in a major medical journal in June of this year. So just 2 months ago, 3 months ago, I published this. I'm kind of tired, I'm sorry. 3 months ago. The use of this combination therapy currently in African Americans with heart disease, even though it saves lives, is less than 10%. Now, you can quibble all you want about the appropriateness, inappropriateness, or the cost, or lack of cost, or anything else, but when you've got something that will reduce your risk of death by nearly 50%, and you have a patient population that's dying from this disease, and fewer than 10% of those patients are getting the drug, there's a problem there. And that's something that we continue to fight. So what can be done? Well, a couple of things can be done. Education is important to make people understand their risk. Awareness is important so you know that you are at risk. Access is incredibly important. We talked about the medical home, and equity is especially important. I represent the American Heart Association, and I'm humbled to be the incoming president. I'm not sure exactly what I've signed up for, Stephanie, but we'll give it our best shot. But, thank you. But this is what we're doing. We have a phenomenal program called the Power to End Stroke. There's a booth at this meeting, open tomorrow. You can go by and become an ambassador for the Power to End Stroke. This really focuses on the African American community. It is a phenomenal program, and it's about awareness. Get your blood pressure checked. Get it treated if you have a problem. So go by the booth and check out Power to End Stroke. Go Red for Women. It's not a white thing. We have engaged over 500,000 women across the country, and 91% of the women that have signed up have some form of heart disease. It is a multi-ethnic program. Sign up for it. Lots of information, lots of opportunities. In the community, we have Search Your Heart. Goes into the African American churches and talks about blood pressure, and gets people on board, gives people menus that are culturally sensitive. You already heard the representative from Pepsi-Cola talk about their relationship with the Clinton Foundation Alliance for a Healthier Generation. We, too, have another leg of that relationship and are delighted with Pepsi's support. We're delighted with the support of the Robert Wood Johnson Foundation. We believe this is incredibly important because it's targeting our youngest citizens, the next generation, and helping them with heart-healthy decision-making. For the consumer, you can go to our website. You can pull up the heart profilers. You can calculate your risk for a heart attack. You can actually plug in your blood pressure and get it managed online so you can chart your outcomes. We have a program called Choose to Move, which focuses on fitness. We have a huge program called Face the Facts. We've done a number of national media campaigns in all the urban markets to make people understand that when you get those French fries, when you eat that donut, that's a problem. Anybody in this room heard of trans fats? Good. Anybody in this room still eating trans fats? Everybody raise your hand. Anybody had a donut in the last month? There you go. So let me just give you a sense of what this burden is. Trans fats are synthetic fats that were designed to maintain shelf life for food items. Typically, you should have about 2,000 calories per day. Those calories have to come from fats, protein, and carbohydrates. If just 2% of your caloric intake comes from trans fats, and you happen to be a woman, that increases your risk of heart disease with nothing else in the mix by 23%. Now, how can you get to 2% of your caloric intake with trans fats? 2 donuts. So the next time you are at a gathering and you see that tray of donuts and you pick up 2 donuts, that means you're trying to check out of this place. Because that is simply not an appropriate decision. You can also go to my grocery list. The other thing we were doing, Stephanie Moulton is with me. She's from the Advocacy Office. They do an amazing job advocating for issues that are important to all of us in this room. Heart for Women Act. You've heard about the Caucus already from Congresswoman Christensen. Heart Association supports that. The Fit Kids Act, we support that. My daughter and I came up here in April, and she was talking to Congress people about how important this was. Tobacco control. We have got to do this. We have got to get this tobacco bill passed. There's just no question about it because it's focusing on our young adults. We've got to get that done. The Stop Stroke Act, we hope that before Congress is out this session, we'll finally get this bill passed. We've been trying for 6 years to get it passed, but we have to do it. And it's revenue neutral. It's just giving us permission. That's all we want is permission to use government resources to make people aware of their risk. So we don't know what the holdup is, but we hope it'll finally make it through. Tonight at 5 p.m., the American Heart Association is releasing their 2008 healthcare reform statement. We haven't done one of these since 1992, 16 years ago. I'm one of the authors of the healthcare reform statement, and we insisted that it appropriately address disparate healthcare and access to care, and we're releasing it right now to get it in the mix so as we go into this political season, we won't be dismayed because we're dealing with this $700 billion this and that and the other, because you know what? If we don't have a healthy population, the financial markets won't matter. So we have to embrace health. We have to do this. So in conclusion, and I think we're stopping on time, We have a unique burden of heart disease, in part because we have a unique distribution of risk. Healthcare is not distributed equitably, and the biggest point of inertia we have is this subtle but real influence of bias and stereotyping in the decision making. We have to find a way using education, awareness, research, science, and advocacy to overcome these issues. It is the only way we can look forward to a healthier future. I'll leave this phrase with you from a 17th century, 18th century English author and poet. Knowing is not enough, we must apply. Willing is not enough, we must do. So I've given you the knowing today. I hope you leave this conference with the willing to do something about it. Thank you very much.
Thank you so much, Dr. Yancy. I knew this was going to be an excellent presentation. Thank you for that. We actually are waiting for our other guest to come. So in the meantime, we can move forward with some Q&A with Dr. Yancy. There is a mic in the middle of the room, right around here. So if you are interested in coming and asking him a question, please go ahead and stand online. Thank you.
Hi, Dr. Yancy. Thank you so much for this critical presentation. My father is 78 years old, and he has survived the last 20 years on one main artery. And 20 years ago, they gave him like 6 years to survive. Over the last 20 years, his diet has been exceptional. He's gotten a lot of care. But I was just home in Michigan on Sunday, and I noticed with his breathing is so labored, and in his speaking, I can hardly hear what he's saying. So I was wondering if he's a candidate for the dual therapy that you just talked about, and I wanted to know if you can elaborate a little bit more. I also saw a program where they're doing a lot of revolutionary work in research at Henry Ford Hospital in Detroit, and I just wanted to find out how to bridge that gap. Thank you.
Well, thank you for your question. And first of all, let me express my concerns for the health of your father, because I've been through that. My father died of heart disease and stroke, and even though we weren't close, it was still a painful loss, and it was a premature loss. There's several things you spoke of, and let me first of all, for the sake of the audience, help you with something. The size of your closed fist that I'm holding up right now is the size of your heart. And the way your heart gets blood is that there is a crown of blood vessels. It looks like these three fingers. It fits over in this manner. So there's one blood vessel that goes down the front, there's one that goes around the left side, and one that goes around the right side. Now, this is my ink pen today, and if I retract the ballpoint, there's an orifice through which the ballpoint emanates. That's one of my doctor words, emanates. That orifice is the size of a blood vessel that supplies blood to your heart. These are not giant ropes. These are small blood vessels. Now, the one that goes down the front actually is the one that begins right up at the top with two together. Where the two are together before they split to go around the left side and the front is the main blood vessel. If you have a heart attack in the main blood vessel, we as physicians call that the widowmaker, because you typically don't survive. So first of all, it's a good thing that he's managed to get through with his heart disease as long as he has, and it shows that we can't predict anything. I'm not in the business of doing that. Somebody else takes care of that. But the issue that you describe is one that could be, but I can't swear that it is, consistent with having developed a weaker heart muscle. If he's developed a weaker heart muscle, there is an entire portfolio of therapies that are uniquely beneficial for patients with heart failure. I am here now because I took a late flight in from Toronto, Canada, where we had a 4-day meeting of national and international investigators and thought leaders about heart failure. We can do something about that disease. Previously, we didn't think we could, but now we can. And so all is not lost. Keep your chin up and encourage Dad to keep his chin up. But talk to your physicians about whether or not he has heart failure. and a number of different strategies might be beneficial, okay? So she wants me to further elaborate on this dual vasodilator therapy. First of all, if you go to the KaiserFamilyFoundation.org, there is a program that I did on that internet site with 2 others in August, so it should still be up. And it deals with not only disparate health care, but deals specifically with these issues of this combined vasodilator drug. But what we demonstrated is that when this drug is added to other usual drugs for heart disease, but specifically for heart failure, we were able to cut the risk of death by 43%, the risk of having to go to the hospital by 37%. People felt better. The dilemma is that it's 2 old drugs, so they're available generically. There are some side effects. You have to take it 3 times a day. And a lot of people, and again, I might get in trouble here, a lot of people, black and white, took great exception to having a drug which was, for the first time, approved by the FDA with a race-based indication. I was part of the group that went before the FDA to plead and present the case to get the approval. They accepted it and said, for those persons that happen to be black, this is an appropriate drug. And I'm in a 4-year-long debate with many people across the country about the appropriateness of doing that, and that's been an impediment to getting the drug taken up. But I still maintain that we're not talking about a cosmetic disease. We're talking about hundreds and thousands of people that have died in those 4 years that we haven't been able to get uptake. So, I mean, I can tell you more because it's a big issue to me, but suffice it to say, for your father, there are lots of other treatments, and someone just needs to work that process out. And there's some very good people at Henry Ford Center. I know several people there, and I can give you names offline. Yes, sir.
Thank you, Doctor, for all the information, and congratulations for your election.
Thank you.
You mentioned a difference in risk between non-Hispanic blacks and Hispanic blacks. Could you elaborate a little bit on that, please?
Yeah, we've actually been very interested in this because there's a big debate about whether or not the differences we see in heart disease are as a function just of socioeconomics, a function of ethnicity, have nothing at all to do with race or ethnicity. And the only way to sort that out is that we have to look at other ethnic groups and identify if they too have the same sorts of stresses or issues related to having heart disease. And what we find is that Hispanics are very similar to African Americans regarding their burden of heart disease, but they don't have quite as much, but they're 1 or 2 generations behind the exposure to a westernized culture. And we believe that once they've been exposed to Western cultures long enough, it'll be exactly the same. I think the other speakers here.
Absolutely. Allow me to interrupt you for a moment. In addition to Dr. Yancy, we were very fortunate to have Cullen Jones, as many of you know, Olympic gold winning swimmer. He's actually here with us, so he's going to come say a few words to you.
Well, good afternoon. Sorry, it's been quite the morning. I was actually in New York doing the Today Show, pushing my initiative, and I'm very blessed and happy to be here. I'd like to say thank you for having me, CBC, for working so diligently. Knowing the subject line, I feel that my initiative to try to get more African Americans and Latins into swimming is very, very focal and very, very parallel to this issue. Exercise is one of the key things that I try to explain to even my own family members. I mean, I have a cousin who's over 300 pounds, and I've told him many times, you need to get out, you need to do something. And I know it's very, very hard, especially for our culture, to get people to understand the importance of it. And with my position being in this platform to try to help more and more African Americans understand that swimming is an amazing, amazing way to get in shape, to stay in shape, to help those of color to break stereotypes that we physiologically cannot float, swim, do anything. And that has been my goal for a very long time, is to try to break that. I know that since I've been put in this position, a lot of eyes have been on me to try to work with that, and my diversity program is up and running now. We're going to have a little get-together in Philadelphia where we're having a Dash for Cash, which all proceeds go towards setting up actually another event across country. But I can't stress enough how happy I am to be here, how blessed I am to be here, and thank you for having me so much. Thank you. And I'm sure I have a few minutes for questions if anybody has any questions. I did bring my medal. So.
I'm not going to let you off so easily.
There we go. Is that better? That's good? Okay.
Congratulations on the gold. My name is Danielle Stanley. I've worked for Smooth Jazz 105.9. And I have a company called Achieve 79 Success Coaching, LLC, which teaches people to get wild with healthy habits. Mm-hmm. But what I wanted to ask you was, what inspired for you to swim? Out of all the different sports you could choose from, who was it, or what have you that encouraged you and motivated you to swim?
Well, actually, when I was 5 years old, I almost drowned at a water park.
Use that adversity as a resilience point?
I was almost a statistic. And that's why it's so close to my heart. I was at an amusement park, and it's really funny to me that when I talk to especially black kids, I'm like, so do you guys like the water? Yeah! Everyone raises their hands. How many of you guys can swim? And then hands drop. And that's what I'm really trying to change. I mean, like I said, I almost drowned. And ironically, I became a gold medalist. So I think that in this situation, it's my job to help.
Well, as a social worker, that was great that you were able to use that adversity as a resilience. That's constantly what we're trying to teach people. Thank you so much.
Oh, anytime.
Congratulations on the gold.
Thank you. Thank you.
Thank you so much. Your comments were so very timely, because my question to Dr. Yancy was to elaborate what role does exercise have to do in preventing heart disease. So your comments were very, very timely. Exercise and drinking water.
No, I would actually like to echo my congratulations for your efforts as well. As someone that couldn't swim as a kid, I know what kind of accomplishment this is, so that's terrific. And you heard what he said, which was so important. He had to work through breaking a stereotype. It's the same thing I shared with you, that it's these stereotypes that impede our access to care. Now, the issue on exercise is very important. There are any number of data sets that continue to demonstrate that those who exercise typically outlive those who don't by about 9 years. And here's another important point. If you have high blood pressure, and just being in this room and looking like I look and like you look, is probably 60% chance that you have it, whether you know it or not. Exercise alone will reduce your blood pressure almost as much as taking medicine. So if you're taking medicine and I don't like the way that stuff makes me feel, it makes me all draggy, if you get out and exercise, it makes it a difference. Now, you could swim to exercise, but you know the simplest thing you can do is walk.
Yeah.
30 minutes a day. It's got to be every day. You need 210 minutes a week. But if you get out and walk 30 minutes a day, you can dramatically lower your blood pressure, dramatically drop your risk for heart disease, and everybody can find a way to walk.
Hi, I'm Melanie Newkirk from Los Angeles, California, and I have the opportunity of swimming 3 times a week. You see my hair, people? Nice. And I tell people to, do it. Get your hair braided or something so that you could do that. But at the Jesse Owens Pool in the county of L.A., we have around 125 women that come every morning for exercise, black women, over 50 and what have you, all sizes and everything. So that's a good thing. And I was wondering if you could hear me through the TV when I was cheering you on in the Olympics.
I think one of the biggest questions people ask me was, where was I?
Yeah.
Because I wasn't behind the block with Michael or Garrett. I was actually on the side. I was so tired that I grabbed the ladder to get out. And if you look on the bottom left, I was in the perfect position to watch Jason hit the wall. And you see this little figure jump up. That would be me.
That's great. The other question is for Dr. Yancy. I was going to call you Dr. Oz because that's my point question. Dr. Yancy, is it possible that you can get be a Dr. Oz for people on TV, because Oz is so effective on not only the Discovery Channel but on Oprah, to teach people, most especially African Americans, about the care and the diet and things to do, because most times people take care of other people but don't take care of themselves, most especially women.
Well, I'm humbled that you would say that. I actually know Mehmet personally. And the only time I got invited to go on Oprah's show had something to do with dating. I thought, there's no way I'm doing that.
I heard that.
Absolutely no way. But, I think Stephanie will echo this. I don't shy away from any invitations to talk to people in the community. And the truth of the matter is that I really relish the smaller groups where we can have this kind of dialogue. I love the radio format, particularly the call-in, because it's less about the presentation, it's more about the principles and the information. And if I have an engaged audience of just 2 people, I'll talk to them. So anything that we can do through the Heart Association, through the Advocacy Office, through the Public Affairs Office, we'll sign up for it. But thank you very much.
Thank you.
I nearly drowned when I was 5 also, and I've never swam since. So maybe you can talk me into getting back in water. Doctor, I'm with the Department of Agriculture, and of course, we have healthy choices and all of these other things. I'd like to talk to you about partnering later, but I wanted to give a personal testimony because I just think that many times we don't tell the truth about what's happening, and we could help somebody else. And I'm one of those folks that doesn't have a hospital home. And 2 weeks ago, Friday, I drove myself to Howard University, I'll say it, hospital, which in our community here in Washington, D.C., if you're not from here, it is not considered the #1 hospital. But I'm a community-based person, and I believe in our community. So I didn't think it would be that bad. After 3.5 hours sitting in the waiting room and being treated like a non-person, I was humbled to the extent that it is definitely motivating me to action. How can we start to impact what we know are invisible issues of access, regardless to how much money you have? Because I got the government Blue Cross Blue Shield that pays for everything. But it doesn't matter if the service isn't there. The other question that I'd like to leave you with, or ask if we can follow up on, how do we broaden the coalition building and the collaborative effort that yourself and PepsiCo and others have started so that we will have a greater impact? And one announcement, on this Saturday at Matthew Memorial Baptist Church, anyone that lives in D.C., there is a free screening, absolutely free, starting at 10 o'clock in the morning, and a group of doctors have volunteered to come. I happen to work with that social action group, and we really do want the community to come out. And if you're just in D.C. and you want some free screening other than just here, please go. It's at 2616 Martin Luther King in Southeast.
Thank you for your statements. Let me very quickly address it as the hour is running short. I don't have all the answers, and I don't know that anyone has all the answers. But I can tell you the things that are most helpful have to do with raising awareness, what we're doing today, because each of you have now been appointed an ambassador to go forward with the message that you heard today. And as we do that and penetrate and permeate our community, eventually people will get it. The other thing we can do has to do with embracing a quality initiative. Increasingly, quality measurements are important in healthcare, and quality measurements are colorblind. Institutions want to achieve the highest quality scores because it affects reimbursement. That's the leverage. And so we're working very hard to be certain that the quality issues are addressed across the board. And in the recent Medicare bill that was passed, the Heart Association worked very hard to get disparate healthcare issues embedded in that bill so that there would be public reporting by race, gender, and ethnicity of adherence to quality, which will hold people's feet to the fire and say you have got to be consistent in all groups that you serve. It's a small step. It doesn't address the question that you had to deal with, because I too had a dilemma where many years ago my daughter injured her foot. I wasn't comfortable with it. I took her to my own institution's children's hospital. I was a faculty member. 3 times I got asked to show my Medicaid card. And I'm a faculty member there. I work at another institution now, but nevertheless, you know, these are the kind of embedded issues that go with stereotyping and bias that over time we have to address. Nobody's got the magic pen. We'll make this the last question if that's permissible.
Yeah, I just have a question. My mother's overweight, and I'm very concerned about her in terms of, like, most of her weight is concentrated in her midsection, and I watch a lot of Discovery Channel stuff, whatever. Too, and are there any things being done, not even targeted towards black women specifically, but in terms of campaigns or initiatives for like public awareness? You see commercials for 10 o'clock where your children, like, you know, about women in terms of taking care of themselves and their bodies and how it makes them more of a risk.
So a couple of quick answers. I mean, I'm sure there's a long laundry list of resources, but go to our website, AmericanHeart.org, and look at the Face the Fats campaign. The reason I want you to go there is that you can calculate what your ideal body weight should be, and then you can download recommended menus to help you get to your ideal body weight. Go to Choose the Move. It will help you with tips on exercise. If you work for a company that has to be a Start Walk campaign, it's a specific program in the Heart Association that's widely distributed across the country where your companies have been designated as being fit-friendly. Take advantage of the campaign. There are resources available. This is not a time where anyone has to say, I don't know how to do this. It's on the web, AmericanHeart.org. Yes, sir.
Great. Thank you for taking my question. My name is Dr. Baruch, and I'm from the Michael Baisden Show. And I wanted to ask a question. I wanted to ask a question about what type of resources you all have available for those of us who are in the trenches, who are teaching health literacy, who are trying to keep us from going down the road of eating the trans fats and the other bad-for-you products that are made so readily available to us, and especially the low-income communities. Is there any way that I could contact you or someone in your organization who might be able to assist us with what we need is, of course, financial resources in order to spread this message broader and wider to touch more people?
No, it's a great question, and absolutely we have resources. There are web-based resources. Mm-hmm. The Search Your Heart program, the Poverty and Stroke, it's a fantastic program. Mm-hmm. And you really should take a look at that. Get engaged with your local affiliate, your local division here in the D.C. area, and the affiliate that serves the area. Before we leave the room, if you'll give your contact information to Stephanie, she can give you my contact information. I will respond if you get in touch with me.
Great.
We will try to do whatever we can. Everybody's resource constrained, but this message is too important, and we have the resources on the web, and I've discovered over the last 5 years that everybody has access to the internet, income notwithstanding. So that's a way to get started. But Face the Fats, Search Your Heart, and Poverty and Stroke, great resources that specifically address what you're looking for.
Okay, and no grants? Do you have grants from within the American Heart Association?
We have investigator grants, which means that if there's someone in a community that wants to do research on the issue and puts in a request for a grant that then is competitively reviewed, that would be an opportunity. Okay. So again, we can discuss that offline as well.
Great. Thank you, sir.
Thank you very much for your time and attention.
Thank you both gentlemen for your insights and for your time. And thanks to all of you for coming and for staying. Always very happy to see you. Please make sure you fill out your evaluation forms. You can leave them on your way out on the table right outside the room. Once you step outside, you will see some white gift bags from PepsiCo. Please take one. And we hope to see you soon again. For those who are staying, there is another forum on post-civil rights African American leadership in room 209AB, down the hall, over to your left. Thank you.